Dr. Andrew Phillip is the clinical lead and senior director of partnerships for Primary Care Development Corporation's Clinical and Quality Partners team, and have really enjoyed speaking to him, hearing a primary care, more focused perspective on this topic. So I think we have his slides, and Dr. Phillip, so excited to hear you speak.
Great. Thanks, Julie. Can you see my slides all right?
Perfect.
Okay, wonderful. And thanks for the introduction. I have to admit, as I've been sitting here listening to these fascinating discussions, I'm wondering, have I been set up? These are the exact kinds of things I'm wondering about and asking about. And so, in fact, to hear so many good answers is very encouraging. As you'll hear, I'm not necessarily a sleep expert, and neither is our organization, but it's kind of an area that we've stumbled into, and I see great potential. And so it's exciting to get to come to these kinds of forums and explore a little bit. So a little bit about PCDC, or Primary Care Development Corporation. We're a national nonprofit. We're based here in New York, but we were founded in the 1990s, really to address a fundamental need around health equity. There was a recognition in New York City that primary care, as sort of a fundamental foundational entry point to services for good health, is not equally accessible, especially in underserved, disinvested communities in New York and all over the country. And so we were founded to change that, to invest capital, to actually build up the primary care infrastructure, to provide training and technical assistance to actually enhance the delivery of quality primary care, which includes behavioral health, includes things like basic sleep health, sexual and reproductive health, and others, and to sort of transform the system through advocacy and also supporting research that really enhances equitable, accessible, high quality primary care. And kind of stemming from our days in the early 90s in New York to now nationally, we've done a pretty good job, I think. We've worked with thousands of healthcare organizations, public health departments, and others all over the country. We've invested now over actually just recently $1.3 billion into the primary care system, particularly in underserved communities, and really built the capacity of the primary care system to grow visits. And so this is the world that I've spent the last few years thinking about, is primary care, and sort of how do we make primary care better? How do we make it more accessible? And certainly sleep has become part of this. But I'll give you a couple examples of the kinds of things we do. One aspect that actually touches sleep quite intimately is trauma and adverse childhood experiences. We know that traumatic experiences, including things like discrimination and racism, as we've been talking about, especially recently, they carry with folks through their experiences and certainly through their health and even their sleep. So some of the work that we do, for example, where we sort of connect the dots, is we invest in innovative primary care models. For example, health centers, Henry J. Austin, who was sort of able to use our capital to basically rebuild and restructure their facility to be safer and more welcoming to patients from all walks of life. While we did that, though, we also help with consultation on how to design that space. We work in states like California to work on large statewide screening projects around childhood trauma and adverse childhood experiences, and really implement that at scale in primary care. And I think that's part of what I'm going to sort of connect to sleep here. We do this with integrated care, physical and behavioral health integration, and others, but I'm just going to jump into it around sleep. So we sort of got to this place about a year and a half ago, as part of our federal, actually a subcontract we have through the federal government, the National Council for Behavioral Health, and specifically through SAMHSA, which is the Substance Abuse and Mental Health Services Administration. We do projects around integrated care, learning series for healthcare providers and stakeholders around sort of how to innovate to really bring together the head and the body and treat them within the same place within primary care. And so this past year, we offered this year-long series on sleep health, really identifying this as a core opportunity where there's an intersection between behavioral health or even mental health and physical health, as much of the presenters here have been speaking about today. And I think we were pretty successful. We engaged over 2,000 audience members from all around the country, including policymakers, researchers, clinicians, and leaders. And it really across all sides of the spectrum, from sleep medical specialists to behavioral health folks, students, and others. And our series spanned a number of topics. So we talked about addressing sleep and acknowledging sleep disparities in places like health centers. We actually had a few NIH-funded researchers come on and talk about some of the research you heard today in terms of disparities and how that impacts sleep, but also how sleep can then impact the outcomes of experiencing things like discrimination, which is fascinating. We talked about sort of clinically, how do you address sleep? How do you assess for it? How do you intervene, both on a behavioral and a medical component? And I think importantly, and as you've done here today, we had sessions that were really dedicated to hearing the perspectives of patients, children, adults, family members, people with lived experience who've gone through the process that I think Farah really nicely outlined today of what the sort of journey is to really get care for sleep. And then sort of this final discussion on actually about us as healthcare providers and what about us in all of this. And, I'll just sort of share this quote from Eugenia, one of our presenters, a sleep advocate herself, and someone who shared her personal healthcare journey, saying, professionals really just they don't talk about sleep. They'll ask you about all these other things. She lists out here vision, how your body pain is. But she said, it needs to be on the radar. If our medical professionals aren't asking about it, how do they expect us to feel and really know to worry about it? And so she's really, saying, I think, the words that we're all saying, which is, especially in primary care, if it's not being asked about, that's quite a problem. But again, as I was listening to the presentations today, I'm thinking, well, okay, I'm definitely preaching the choir here. So I snuck in and I updated my slides for a second. So, I think Dr. Prillis really laid this out nicely, right? So what's the problem in primary care? It's all the things he just outlined. I totally agree. It's sort of the patient awareness. It's the provider time and sort of awareness, having those pathways. And to Dr. Huang's point, also the engagement. I'll sort of share a couple other things. And also, in fact, I didn't add this in just now, but it was cool to see that Dr. Gradner is here as well. This is such a great, this concept of sleep as a vital sign. So again, that's sort of, I feel like I've been duped, but in the best way. So I'll just add a couple of things to what's been said already, right? Primary care is a central access point for all care, for behavioral health, for physical health, and even for sleep health. But, as you already know, visits are short. 20 minutes is probably the highest number I've seen. And a lot of that is often actually eaten up by interacting with the electronic medical record and things other than sort of the patient's needs. And in fact, and this might get to the policy piece a little bit, although we here are talking a lot about primary care and the great opportunities of primary care is essentially the least reimbursed healthcare service we've got of the major sort of access points. We're talking about pennies on the dollar of our national healthcare spend goes to supporting primary care. And here, as you can see, just 5 to 7% versus sort of the behemoth, which is like hospital-based care and other forms of care, things that sort of happen later in kind of clinically speaking, like a disease process, right? This is sort of not an emphasis on prevention and early intervention and sort of emphasizing good health. So that's already a problem, right? So there's not a whole lot of resources in primary care, despite the fact that conveniently a lot of us are talking about it. Also, there are a lot of demands in primary care on the providers and providers, including the whole team. The U.S. Preventive Services Task Force, the U.S. SPSTF, they sort of outline, gold standards and what kinds of things you should be asking for and screening for. And, we're often disappointing them because we're only screening for like less than half of all those things they want us to be screening for. In primary care, we are an ecosystem of testing and of innovation. There's always new screeners. There's colorectal cancer screening. There's breast cancer screening. There's depression screening, suicide screening. There is a screening for diabetes, different levels of diabetes based on the types of medications you take and your diagnoses, cholesterol, a whole number of other things. And these are all sort of required. And then we see an influence of payment. And so, in fact, the things that we ask questions about, the things that we screen for practically when you go into a primary care office, they're certainly influenced by best practice, but they're heavily influenced by what is required and what is paid for. And that is a really important distinction, I think, to make. So with that all in mind, some of these studies, I think this was actually cited in Dr. Greiner's work, PCPs tend not to really ask these questions very much as a reality, but like less than half the amount of time, for example, that they may ask about exercise or someone's diet, which are important, but as we see here, sleep is very important. And we have patients who, again, are asking about this. So what do we do? Again, rip from the headlines, my quick camera work here. I thought Dr. Huang's presentation on these two sort of questions, I'm like, yes, this is actually what we've been asking for, what I've been asking for. And so, in fact, Julie and I got set up through a meeting that was originally put on by Dr. Mishka Brown at the NIH, because this question came up. And actually, I asked Dr. Brown this question a few months ago, coincidentally, of what is one key question that we can ask about sleep health in primary care? Because we have only a few minutes, we have very little reimbursement and sort of money to play around with, and we have very pressed patients and providers who don't always appreciate the importance of sleep. But I do think, and sort of in primary care, there's a good sort of, understanding that a sort of core question or key question, or maybe two questions, is very important. Julie, you put out a paper on this as well, which is what I've kind of screenshotted and stole from the headlines up top there, where you laid out two questions. In my conversation with Dr. Brown, she suggested perhaps asking about excessive daytime sleepiness may be a good core question. And so it's encouraging to see that there's so much research attention being paid to this. However, I will say this is not yet widely heard about or known in primary care. And when I say primary care, I'm also talking about not only large health systems, but also small solo practices or group practices. In fact, in places like California, which I'll talk about in a moment, a great deal of particularly underserved and vulnerable communities, they really rely on small practices, sometimes single provider practices, to understand the needs of their community and to get care. And they're often sort of the last ones to kind of catch up because they just don't have the luxury of participating in even wonderful forums like this all the time. But one thing that really encourages me and made me think, and this is a conversation I had with Julie also, is, I mentioned earlier ACEs Aware. This is a California-based initiative funded by the Office of the Surgeon General and through their Medicaid funding, Medi-Cal in California. And they took this issue of ACEs, which is adverse childhood experience. This is essentially stuff like having a parent who's incarcerated, spending a night as a child, not knowing where your next meal may come from, not having access to things you need. Earlier we heard about the social determinants of health, that kind of stuff. And it turns out the more of these things you're exposed to as a child, the more barriers and challenges you're going to have in achieving and enjoying good health, among other things. California's acknowledged this. And similarly, they said, well, nobody's screening for this. Nobody's asking about these things. And so it's hard to do anything about it. What they did, however, is they took two things. They took a whole bunch of money, like billions of dollars, and decided we are going to get behind screening in primary care for adverse childhood experiences, things including childhood trauma. And we are going to, one, create statewide initiatives to train healthcare providers how to screen for, how to ask for questions around adverse childhood experiences. And two, we're going to tie a special reimbursement incentive. We're going to pay providers per screener to incentivize them to ask these core questions. And then we're also going to support them in thinking about engagement and follow through some of the points I brought up earlier. And as you can see on this little graph on the bottom right here, if you can't, I'll just tell you, basically, they've had a many-fold increase now in screening in the state around ACEs, these adverse childhood experiences. And this is just in the span of less than a year since this initiative was started. And what this tells me, this is not a one-to-one comparison, and there's definitely flaws in how this has been rolled out, and there's problems still, but it makes me think that if we can sort of, get the right partnerships together, if we can get a reimbursement perspective and tied into this, if we can get academic perspectives to sort of let us know what these key questions are, and we can get the right sort of industry standards, as others have mentioned, we might actually be able to make some progress here to the points that everyone's making. So our plans are to make these connections. We're sort of one of many voices of primary care, but there's these practical issues that we need to sort of wade through. And I think a big part of it is really acknowledging the need for proper reimbursement and regulation. And that's kind of what my sort of call to action will be is as we sort of engage in sort of the translation of this. We talk about translational research and how do we get information from researchers through clinicians in the community, but also how do we get that connected at a policy level? How do we get the conversations going, which I'm very interested in with health plans, with Medicare, Medicaid, and others, to make sure that there's some bite behind sort of the bark of we need to do the screening. because we have to make it practical and we have to acknowledge all of the other things that are going on in primary care. But I'm very excited and very encouraged by this discussion. You can view our whole series. It's free. It's online at pcdc.org/sleep. You can also find my discussion with Dr. Brown and others around sleep. And we'd love to have partners in this work. And I think we have some here.
Thank you so much. I think this is just such an important piece of the puzzle that was missing for me for a long time in understanding, one of the things you said, the things we screen for are heavily influenced by what's required and paid for. And that discussion of getting the reimbursement and the payers thinking about this and possibly following a model like ACEs Aware just really gets me excited.